So what is PEF? And, how does that relate to the immune system? Particularly, I wanted to touch on tertiary lymphoid structures because, you got me going down rabbit holes because PEF has really been shown to actually stimulate tertiary lymphoid structures.
That's correct. Yeah. I mean, it's so interesting, there's.
And then talk about, other ablative techniques. Because I had a patient today going, why can't I get cryo? Why can't I get cryo? Remember the son of that potential patient in Lebanon.
Yeah.
Yeah, well, cryo. And you had to step in and go, no, remember, I've done more cryo in cancer than anybody.
Yeah. But, I mean, I've always done lots of ablations. I mean, we looked at all the ways of like trying to kill cancer. You can stick a needle in tumor, you do heat it, which, generates through like radio frequency or microwave. That's a heating, killing, or, do you freeze it? What's the method that you kill it? And then what is the result when you kill that way? And pulse electrical field, is a way where you're basically electrocuting the tumor, right? I mean, you're like shocking it, and that kills it in a way that actually makes the immune system want to come to attack it. And that's more so than the others. And it's really interesting concept that, the ways that you kill the cancer can, boost the immune response differently. They're not all the same. I mean, there's obviously there's also parts of like where in the tumor do you treat? You don't, from an immune standpoint, you don't want to damage normal tissue. You want to damage only cancer, right? If you start damaging normal tissue, then you're going to suppress the immune response. So you need to be in cancer. And then the other part is like when you're in the cancer, there's better parts of the cancer to be in, right? You could look at a cancer and there's some parts that are more resistant and some that are less. And so you can see that somewhat on some imaging when you put it all together and know where you should target in that tumor and where's sort of the main nidus, where's like the main forces that are causing all the problems and go after that. And then you kill and ablate that area. And then you distribute some immunotherapy in that location and recruit all the troops in that area to go attack it.
Yeah. So, just basic question, starting off with, innovation. I find it really interesting because, there will be people that talk the talk, right? Innovation. Yeah. We are not resting on the laurels of yesterday. We're pushing forward into the future. And then there are those that actually walk the walk of innovation. And I think that, the Williams Cancer Institute, which this is our first podcast where, we're working together. And it's super exciting because having now been working with you for 5 months, it is innovation in action. And people look at that word and they go, okay, what does that word mean? And it's like, it's actually something that you can actually see tangible at Williams Cancer Institute. And I think the pulse electric field therapy is a perfect example of that. But people continually are confused about what it is. So I guess first is just, what is PEF, pulse electric field therapy?
Yeah.
Just a basic, kind of descriptive.
Yeah. So, it's interesting because they started looking at this technology, and I think they really started looking at it in the mid to late 90s and looking at this idea that, if you essentially like shock the tumor and then, how much voltage, how long, how fast, all those type of things, what are the differences? And that's what you get with pulse electrical field. You get these like, there's mainly you have the company Galvanize. You do have a couple other companies that are working on things, and there's several technologies, and who's better hard to say. But the thing is that, the concept is that you're like sending this quick electrical charge into the tumor so fast that it's almost like it didn't even know it happened. Right? It's like, I mean, like, it's like you shocked it, but you shocked it like in 1 millionth of a second, right?
It's like,
right, exactly. And so it was like so you when you put the needle in, it's this this electrical discharge, but so fast, and then the cells react to it, and they start like opening up and dying and things like that. So that's what we're seeing with this pulse field, and pulse electric field, and it's really it's a very interesting technology, interesting concept. Essentially, we're like in there shocking the tumors, but like fast in a certain way, and that's what is, and that stimulates the immune system a lot more than these other techniques.
Yeah, and I think one of the things, or I wonder if one of the things that really people are having a hard time putting their head around is when you look at how the way we have treated cancer for the last 100 years or so. It's been cut it out. It's a traumatic procedure. It's chemo, which is toxin, destroys rapidly dividing cells, and then it's radiation, which is very, in a similar manner, destructive. So they think about tumor in that kind of war mentality, but it's like, no, this is just energy.
Yeah, it's interesting. It's like you have like a whole how you put like there's you want to attack something, and you go right in the center of it. You put it in there, and you put in like a bomb that just blows right inside of that, and just takes that down. I mean, but doesn't affect all these other cells outside of it. It's really amazing and precise that it's right in there in the tumor, and you don't have to hit all of it, because like I said, that initial the collision causes this effect after. So it's like it's like you start that initial shock pulse, and then everything kind of goes along with it.
And that's a key point, because when you look at cryoablation, a lot of people, they want to ablate the whole tumor.
Yeah.
And you're saying, no, we don't want to do that. No, we want to ablate part of it. And you mentioned a very specific part of it, but it's actually not just external. We're not going transdermal. You're actually going into the tumor with the probe to activate, the destruction of this process, but at a specific point, not the entire tumor.
Yeah, it's like, obviously, everybody wants to look at ablation like as a surgical type technique. Like they want to say, oh, so you need to like kill all the tumor, and that's their mistake. They're not looking at the immunological. Is that what you want to? This is not to try to go and just like cut out everything. This is to stimulate the immune response, and so it's a completely different concept. And that's. But everybody, instead, they just see, oh no, we want to cut everything out. This is not the way to go.
Yeah, I think that's a good point, because it's like I wanted out yesterday. And I get that from a patient perspective, right? But, this is just like, no, let's activate the immune system in a way that harnesses the power of the immune system, which, you touched on your book, even though it was written, 2019? Is that right?
Yeah, it's like 5 years ago, right? It's like it's
still relevant. Not only is that relevant today, it's still ahead of the curve.
It's so funny, because like last year we went to there's a big immunotherapy meeting that we call SITC, Society of Immunotherapy Cancer. It's a great meeting, and I love it, and I've been going to it for years and years, and a lot of people around me were all going to it, and people who know me know the book, and then so last year, like there was all these posters coming out talking about all the things that talk about like DPP4 inhibitors and other things. I mean, propranolol, and you see all these posters and people showing stuff. And one of the guys in our company, he said, "Hey, I'm gonna ask you a question. Where's your time machine? Because like you had to like have gone like into the future and like saw this and like brought it back, because like it's impossible, because you literally the book was written, but now it's like actually coming into where people are seeing it, and 5 years ago now okay, that people say, oh, that's now it's making sense, but it's amazing.
Yeah, so Back to the Future, we just need a DeLorean now.
Yeah,
and a flux capacitor.
Yeah. So if that's what we were doing back then, imagine what we're doing now.
I mean, that's what I do when I talk to patients and I tell them, medicine hasn't even caught up to the intratumoral approach of what we're doing at Williams Cancer. And we're already innovating in other areas to become, so stay tuned. But, and so it's not like innovation is something that, you rest your laurels on. It's something that, honestly, you can't stop. It's keep pushing forward because cancer keeps mutating, so we can't rest on the successes of the past.
Yeah. Yeah.
Now, I wanted to talk about those tertiary lymphoid structures because I was talking earlier because, you got me going down a rabbit hole with that because pulse electric field therapy, obviously it's a key aspect to ablate and destroy part of the new tumor and create new antigens, but it accelerates the production or increases the production of tertiary lymphoid structures. Can you talk about that?
Yeah, the company Galvanize that developed it, they've done several studies where they were looking and they did like ablations in the lung, and they would see these, and they would do these, they would do like an ablate, and then later they would resect the area so they could look at everything. And so then that allowed them to see what was going on. They're looking like, oh my gosh, look at all these immune cells that are getting around this, and these, and these are what we call tertiary lymphoid structures, which basically is like, if you think of a lymph node as being, I guess, like a military base, right, or something, then these are sort of sub bases that the immune system develops, and what happens is that when there's a cancer, the immune system will start compiling a lot of cells around there to want to attack, but it's not like an official node, right? It was not formed as a node, but it's kind of making like a node-like thing because it's saying, hey, there's something here we need to attack. And when the immune system does that, that is, it's showing that it's going and want to attack things, and that gives you a good sign that it's going to attack the cancer. And that's a big indicator that, immunotherapy is working and the immune response is seeing the cancer. So tertiary lymphoid structures have been a very hallmark of, like, if you see that, okay, the immune system is seeing the cancer, immune system is wanting to attack the cancer, and that's people have a lot of interest in that.
Yeah, I love that analogy. It's a forward base, and it predicts immunologic response and improved outcome.
Yeah.
Cool.
Yeah.
So then if you do pulse electric field therapy and it increases the tertiary lymphoid structures, there are a lot of patients that we've talked about this before where there's a lot of things that just kind of pass themselves down through training. Well, why do we put everybody on corticosteroids? DEXA.
Yeah.
I don't know, because my fellow taught me, and vice versa. Yeah. But corticosteroids can actually suppress tertiary lymphoid structure.
Yeah. That's the thing is that, when you see pre-treatment with steroids in a lot of cases, particularly, they pre-treat with chemotherapies. There's various situations, and they would look at it and you would see like the tertiary lymphoid structure, you give steroids, and then it wipes them away. It eliminates the tertiary lymphoid structures. So we're undoing that immune response. You have to be cautious with that type of thing. It's you can't really do that. I mean, certain settings, but but particularly you want to try to avoid the steroids in most patients if possible. So I think a lot of this stuff. I think unfortunately, like a lot of the way that oncology is practiced is that we're doing things to set it up for failure, right? I mean, to give steroids, to give Tylenol, to give okay, we're gonna give you some stuff and that should help you, and then we're gonna give you stuff that's gonna mess that up.
Yeah.
So that's like kind of what seems like is happening. I don't understand. I think they don't understand the connection to these other things. So
I think a lot of it is they're not reading, and it's so Tylenol's been such a component of chemotherapy, immunotherapy. Same thing with EXA. It's just kind of it is. They don't even think about it.
Yeah.
It's
Yeah, I
just,
mean, obviously for overactive immune responses has a great role. I mean, you got a patient that has an overactive immune response, you need to suppress it. Tylenol, great drug for that. You know, I mean, if we have a situation we give patient immunotherapy and the immune system jumps on top of the cancer super fast, we consider using Tylenol. It's a great drug to slow it down.
exactly.
But yeah, in other cases, when you want you want the immune system to keep attacking the cancer, you don't want to suppress it. You don't want to give Tylenol.
Yeah, because, the best answer to cancer is never get it. Beyond that, though, the best
Yeah.
answer to cancer, it's the immune system. So everything we
Yeah.
can to allow the immune system to do its job, not just against the tumor that's being treated, right? Because with PEF, what you're doing is you're going into a portion of the tumor to create new antigens, new dead pieces of the cell, of the cancer cell. But then you inject in tumor immunotherapy. So it's really the two coupled together, kind of the magic sauce, if you will, that's creating this localized harnessing of the immune system. But that then gets transferred systemic.
Yeah. I mean, but it seems like the immune system is everything for our health. If you've got a good immune system, then you don't get cancer, you don't get heart disease, you don't get diabetes. I mean, like the immune system will keep you healthy.
Maybe even keep you from getting diseases and prevent aging. Maybe, I don't know. Just
that as well, right? I mean, the system seems to control aging. So everything revolves around the immune system.
And I came across this and just prepping for this, that pulse electric field, the mechanisms, it enhances permeability, it increases the tumor-associated antigens, which are these new antigens the immune system responds to, increases tertiary lymphoid structures, it alters the tumor microenvironment. So it's truly a therapy that's changing the tumor microenvironment and helping to overcome the immune resistance that often exists there. It increases immune infiltration into that arena, and then it increases immune recognition and response. So it's almost like when you look at systemic immunotherapy, it's like, well, man, the response rates are about 15 to 25%, just a response rate. And it's like, well, yeah, you're not doing PEF.
Yeah, I mean, obviously there's many, many ways you can boost these immune response, and PEF is one option. I mean, can you start an effective immune response without ablative stuff? Yeah, you could inject just drugs into the tumor and achieve results as well. I mean, there's many ways you can do this, but PEF in certain situations gives an added plus, or gives you that additional immune stimulation. It's essentially another immunotherapy agent for you.
And what I love is, so many patients today worldwide, this is not just, regional, it's worldwide. They're looking for a more natural, holistic approach to their cancer treatment. And PEF fits that to a T.
Yeah. I mean, I think a lot of patients, if particularly like if you're a patient who's getting, let's just say, standard immunotherapy, for whatever cancer you got a lung cancer, you got the breast, you got something that, then the doctors are giving you, Keytruda, or they're giving you Opdivo, or you're getting Yervoy, or any of those combinations. If you could throw in a PEF on that, I mean, you should. I mean, you should do that. And obviously there are more and more facilities that are doing PEF, and so patients should be trying to get that. I mean, they should be requesting to get pulse field if why not?
Yeah. And so when you look at PEF as an ablative therapy, it's not the only ablative therapy, right? You mentioned microwave, you mentioned radio frequency,
right.
Cryo. What kind of helps PEF to stand above those others?
Yeah, so the others can be immune stimulating, but they're very operator dependent. So, for example, cryoablation, and we particularly look a lot at cryoablation, like let's say at isolated breast lesions. So like a patient has a early stage breast cancer, you could go in, you could cryo that lesion. And yeah, that works, and that can do a good job. However, depending on how that's done, I mean, there can be, the immune wise could be positive or negative. It's hard hard to say. I think we need to do some improvement on that. I think there's a technique that we could develop where we could do, cryoablation on these early stage breast cancers and really minimize the chance for the cancer ever coming back, where you would cryo and you would add a few, immunotherapy agents mild to that ablation, and then you would reduce their chance of them getting metastasis. But yeah, and otherwise though, a lot of these ablative technologies, I mean, looking just like, just knocking out tumors here and there, and but yeah, they're the problem, for me, radio frequency, microwave, I don't really have a use for those ever anymore. I don't see a situation that I would ever use them in.
Right. Indeed, when you still hear that people are being recommended Y90, it's like, what?
Oh gosh, yeah, right. So I wouldn't do that. I wouldn't do Y90, but yeah, so most of those regular ablation techniques, just stuff. I mean, look, I've done plenty of them. I was involved in them. I was excited about them originally, and thought they were great. Now we've moved on, and now I think where we're really at is that when you want pure like immune stimulation, pulse field is going to be your way to go. Now if you're wanting to say, okay, I've got an isolated tumor, I just want to kill it all, then maybe cryoablation is the way to go for that. If I don't have cancer elsewhere, for sure, cryoablation might be the way to go on that. Pulse field won't get you those big. So in that situation, you say, okay, well, like let's say if I had an isolated breast tumor, why wouldn't I just pulse field it? And you could, and I'll tell you what we've been looking at doing is, let's say we have a patient with isolated breast tumor, and say, let's bring the patient in first and let's pulse field it and then inject it. Then let's wait a little bit to let the immune response start. And then we come behind and cryo it and get rid of it free, just blow it away. So that we've created the immune response, and then later we came in and cryoed to knock it out. So it's like we created like the vaccine.
Yeah.
And then later we eliminated the disease, the big bulk of it. So hopefully their chance of the cancer coming back. That's the stuff that we've kind of been doing, in those type of